So next what we'll do is look at the hip range of motion. How I'm going to do these in an exam is actually going to be based on the irritability. Generally, it kind of, we always go into flexion first, but generally that's the most painful position, or rotation. So we kind of want to say those last, but we'll just kind of go through it right now. But I would say I would base these 100% on the irritability of the patient and what's going to bring on their pain most likely, and do that one last. So for flexion, what we want to do is just kind of bring up here, kind of hold here, and then what I'm actually going to do very first off is make sure I go into a pure flexion and just check within to make sure any pain's going on there. If there's no pain, oftentimes, or I'll even do this first sometime, is just go up and see what does the hip want to do. Does it want to go off into this side? Does it want to go off into this side? Because if we're going up and they really want to go over there, it's going to kind of go that way anyway. So you can get them to actively do this first, and then you passively do that, and then come over just like that. That is active. I'm going to go. So what I would want to do is all active first, then passive. Active, passive, active motions, combined motions. Now we're going to go passive, and all that's painful, then passive with overpressure. For clarity's sake and just for time's sake, I'm going to go into kind of passive and passive with overpressure, but I would get them to perform it first and then combine motions. So if I want to go into flexion quadrant, I come up here, I can go there, come into there, and I really like the idea of just the spokes on the wheel. Just kind of going all around there to completely clean out flexion, and then going into there, just kind of overpressure, and making sure all while that is pain-free. The second one, what I want to do is a little bit of abduction. So coming over here and going to the point of where they feel pain or restrictions, you can come over here, block on the other leg, and then come over just to make sure you're getting that pure motion in it. Adduction is another one you can come over just into here, bring it over. Oftentimes, I'll be honest, I rarely ever check that, but that is a motion you can get as well. And what we'll do is let's go into internal and external rotation. Before I take them up to 90, a lot of times I like the log roll, just kind of going back and forth. It's a very specific test for any hip intra-articular, any very specific test for hip intra-articular pathologies, coming into that log roll and coming out just to get a good assessment of the mobility. And then we go up into 90. Now, oftentimes when you see clinicians do this, they'll be here, arm here, testing it. This is not hip motion. This is knee motion. So, just for example, if I have her here, look at that internal rotation, man. She goes on for days. But if I grab here, and I've got the knee blocked, boom. That is all the hip internal rotation she has. Let go of that. Oh, nope, I gained about 10 more degrees. So especially with your arthritic knees, you can get so much more motion and you actually lose the hip. Same thing for external rotation. You got it here, going down, boom, right there is the hip. If I let the knee go, I still gain about 5 to 10 more degrees. So you want the true isolate that motion. So, go ahead and flip onto your stomach for me. So for the second thing we want to do is check hip motion, and we want to do rotation as well. So go ahead and bend your knee for me. So you need to test it in flexion, and you need to test it in extension. It's crucial to do both of those because it changes how the hip works. On a block down here, if I get the hip coming up, I've gone past that motion. Testing there for external rotation. Coming up here for internal rotation. And then lastly, what you want to do is go into, you want to go a little bit into that extension. So what I like to do is actually bring the hip a little bit short of 90. Have blocked right here. And just bring up a little bit. Now say that actually can bring on the patient's pain. What I'll then do is try with the knee. So say I go at 90, we bring on the pain. I actually want to get out of that 90 and then try to go up again and see if I bring on the pain. If both of those are painful, the hip is probably what's creating some of that issue, the hip joint or the iliopsoas, because I've not affected the psoas with my knee. So I need to actually try to differentiate, okay, is this like a psoas issue that I'm testing, or is this a hip? Now, sometimes the symptoms can lead you down that way, but more, you can actually kind of do it a little bit different. So, see, I take the hip, turn it into a little bit of external rotation. So pull it in there and then bring up. Now, say she's like, oh yeah, that really brought on my pain. Well, think of what you did there. You externally rotated the hip in extension. You've taken slack to that psoas. It's probably going to be a little bit more of your anterior joint capsule. It winds it up that way. I go internal rotation. I've wound up my psoas. I come up, boom, that brings on the pain. Then I might need to check into the psoas a little bit more. Unfortunately, that's more of a COMT manual therapy nugget. It's not necessarily supported by literature. So, like most of those clinical pearls, we got to take it with a grain of salt, but it's good to know that and look into it. So, assessing the mobility of the hip, one of the best things you can do first off the bat is long axis distraction. Any of our arthritic hips will like it, will love it, honestly. So, a couple ways you can do this. I like the 30-30 slide external rotation, which was written up in the literature a little bit about how they kind of get some loose bodies, like a loose body manip. It's also the open pack position, but basically taken to about 30 degrees flexion, 30 degrees abduction, slide external rotation, and just distracting back, just like that. Now you can always add a belt on the very end. That's another good way to do that as well. But just distract back like that. The next thing that you can do is you can always do an anterior glide. And a couple of different ways you can do this. Generally what I'll do is come, support their leg just like that, and come and get right here. So you have to be very careful with your female patients that you know where your hand is, because it could be a little bit awkward. But just coming into here, making sure your elbow's in the plane, and just kind of dropping down right there, or kind of coming down there. I'm not a big fan of the anterior mob, so I'll do more probably lateral distraction than anything, because I feel you're just getting a little bit too much close and personal, and I don't get that much bang for my buck. So instead of going A to P, you can also go posterior to anterior. Go ahead and flip on your stomach for me. And with this one, I always come down and just kind of weight the leg a little bit. And what you want to do, find the greater trochanter, come up, and generally I'll actually make a fist with this. Now the line of angle, remember the acetabulum sits at an angle, so you actually want to go anterior medially with this mob. So come into here, and then just kind of drop it in. Of course I could get right into there to go down, or just kind of drop in there, and then playing around with it. So right there I don't feel great. Right there, that's where I feel getting some motion. Again, it should be kind of a little bit more anterior and slightly medial, just kind of like the shoulder is. So just dropping down right into there. Of course, you can always enhance it a little bit coming up, but this is assessment, so we'll get into treatment later. So with those two, you can also do a side lying distraction. Go ahead and lay on your side for me. So this is written up in the sense of go ahead and bend your knees for me just a little bit. You can get right into here, just kind of get on the top of the greater trochanter. Usually I'll make like a C with my thumb because it's big enough to kind of get on there. Go and just distract down like that. So trying to get a little bit of that hip motion. I don't find much success with this. I found this really successful with lumbar. Into this area, doing a little bit different, but this is another way you can do the hip. Another way you can do, and this is often how I will mobilize the hip, is using a mulligan belt and performing mobilization with movements. Again, we're not going into treatment, but we are assessing, so I can assess this glide as well. Go ahead and lay on your back for me. So oftentimes you want something between you and the patient, like a pillow. I mean, not between you and the patient, between the belt and the patient, because this can get very, very uncomfortable for them. Go ahead and bend your knee up for me, and relax your knee on down. Perfect. So we don't have anything in here, but we won't pull too hard. So what you want is you want this down as far as comfortable. So oftentimes you can tell the patient to bring it down. If you have any gentlemen, you can always tell them to move the furniture to the opposite side of the room. I'll be honest, every time I've ever seen this mobilization performed, I've always heard that joke. That joke is stolen from Mulligan. It's in his book. So every guy that you ever see, they'll pretend like they were the first to make that joke. It's actually out of the text, which is a phenomenal text to read. But want that down as far as you can. And you bring your leg up. And so oftentimes, support them first. And then play around with it. So you really kind of want it level with your hips. If you have a high-low bed, that's perfect. But what I want to do is get it a little bit slight and just kind of simply hold here and distract back. Now sometimes if you don't get it, you can almost do like a scooping motion just to pull back and just to assess. And you can assess into a little bit of external rotation to a little bit internal rotation, but just assess that joint mobility. The final one you can do is kind of like a little bit of a caudal glide. So everything we've done, we'll assess all motions, but we haven't done inferior caudal. The way to really kind of do this, you can use the belt, but you can also kind of get here, get right down to the hip, and then come down. And it's just shifting your weight back a little bit and working it down. And just kind of seeing, does that, is that stiff? Does that reproduce their pain?